And so welcome everyone to our December OPDAAC meeting. As always, we start as promptly as possible. We're going to be using Q&A this time. So if you have questions for any of the panelists, please use the Q&A for that. But we also have our chat going, and we use that to get to know who's in this virtual space with us and to continue some conversations. But just wanted to be sure that everyone knew that we're going to use the Q&A function to take all questions today. I am Margaret Bordeaux, and again, good morning to you all. Our December OPDAAC meeting and what it has been historically will focus on justice-involved populations. And so we'll also have a session on acquired and traumatic brain injuries. Some of you have done this before, but for folks who are new to this virtual space, the way that we get to know who is all here with us is we have two ways. And so one, feel free to put your name and any of the categories from the poll that we will launch in the chat, right? And so you can tell us your name and the background that you come from into this work. Use the chat box for that. That's also a great place to share any pronouns that you'd like for us to know. And then we also have the poll that you can respond to on your screen. And so there it is. And again, the field that best describes your work. And so we like to get a sense of who is in the room. And so OPDAAC started as a in-person event, but it's been a virtual room for over a year now, and we're getting comfortable with it finally. And again, want to remind you all that we will be using the Q&A function for questions this time. And so there are our poll results. And as usual, we have a pretty diverse crowd here. And we are especially happy to have you all. My colleagues will be monitoring the question and answer function to pull out the questions for the panelists. So be sure to put them there. And again, the chat is just a great space to get to know other folks who are in the room, have some of those conversations, and try to create some of the magic that we know comes from being in person. We don't want to lose that. I want to go ahead and thank my colleagues, Amanda, Amy, and Joe for handling that Q&A. For anyone who's moderated before, you know it's hard to man the chat or the Q&A and also MC. So I'm very thankful for them. This meeting is being recorded, and the meeting recording, the agenda, and the slides, and some bio information for some of our panelists will be shared with you all within 7 days. And that's comes through the same link that you register with, so you don't have to do anything extra to receive that. For the sake of time, I will go ahead and introduce our first speaker. We have Becky Nelman coming from UNC's Injury Prevention Research Center. And so Becky will share an update on IPRIC's justice-involved data studies. And so I will let you take it away now, Becky. Thank you all so much.
Great. Thank you, Margaret. All right, so really excited to be with you all this morning. Thanks for having me. So as Margaret mentioned, I do sit at the UNC Injury Prevention Research Center and in the Department of Epidemiology in the School of Public Health at UNC. And so I'm going to speak a little bit about some of the research we've done and sort of have ongoing right now and where we're looking toward in the future in terms of our research related to justice-involved populations. So next slide, please. Okay, so we've had the really good fortune to work with an active kind of group of collaborators from the Injury and Violence Prevention branch in the Division of Public Health, as well as the Department of Public Safety, the Division of Mental Health, Developmental Disabilities, and Substance Abuse Services, and then a few different entities here at UNC. So through this work, we have a very active work group with these different entities that meet regularly to discuss how research can inform practice and vice versa. And so we've done some collaborative work in a few different areas, a few different buckets that I'll talk about today. The research really does kind of span the sequential intercept model. So it serves to both kind of document the size of issues related to overdose in this population, mental health disorders, and to explore prevention approaches and what might be working kind of best across the state so we can learn from each other. So I'm sure many of you are aware of the sequential intercept model, so I'm not going to go into detail related to it. It basically, right, helps us detail how individuals with mental and substance use disorders come into contact with and move through the criminal legal system, and helps us kind of think more clearly about opportunities for prevention and diversion. Next slide. So these little arrows here kind of highlight the kind of buckets of work where we have activity right now, or where we've kind of historically done some work. So the first one, next slide, relates to work that pertains to better understanding what individuals face in terms of their health risks, right, following release from prison. So a little bit further down on the model, and then we'll kind of work our way up as we go. So next slide. So this was some previous work that was done by our team at UNC with our collaborators that I just mentioned in the Division of Mental Health, Public Health, and DPS, with Dr. Rena Pawala, Dr. Shanahan, and others. And so we've known for quite some time, right, that from many studies that persons released from prison face an elevated risk of overdose. There was like a seminal study that came out in 2007 in Washington, linking prison records to death data that found the risk of death following release from prison, particularly for overdose, was like 129 times the general population. And we've seen studies documenting this in New Mexico and several other states and several other countries, right? So we know this is a very risky period. So we've done some work in North Carolina to look at, what does this really look like for our state? Again, kind of unsurprisingly, unfortunately, like others, finding that really heavily elevated risk. And then did a little bit of work to kind of dig into, okay, well, who's kind of most at risk, and what are some of the risk factors that are particularly elevating this risk? So finding those between the ages of 26 to 50, those with many previous kind of prison terms being most at risk. And we know from other research that there's a whole host of other factors, right? So limited to no access to treatment facilities, lack of social supports, homelessness, or lack of access to essential services. All of these things certainly place people at a higher risk, as well as untreated comorbid conditions like mental health disorders. So next slide. So that kind of led us to our next area of work, which was to dive a little bit more deeply into looking at this intersection of mental health disorders and substance use disorders, and what's kind of being done in this space in North Carolina, right? We know this is a huge issue. We know from national data about 17 million people in the US have diagnosed co-occurring mental health disorders and substance use disorders, right? A very intertwined kind of issue. If you look at the chart below, this is probably unsurprising to many of us on the call, and this is a little bit of a dated figure. And so unfortunately, some of these prevalence estimates have only increased, but what you have on that top chunk of that figure is the proportion of people in these different populations with a diagnosed serious mental illness. And then on the bottom, the proportion of people that have a diagnosed substance use disorder. The gray bars, of course, are the general public. Red represent the prison population. Blue represent persons in jail, and the yellow, persons interacting with probation and parole settings. And again, what you see is a several-fold elevated proportion of people in prison, jail, probation, and parole settings, right, having serious mental illness or substance use disorders, as many of us know. So next slide. So this, as I mentioned, led us to our second bucket of work, where we really wanted to understand some of the programming that's happening in the prison system to improve treatment for individuals that have mental health disorders and what we know often kind of co-occurring substance use disorders. And so this is some really innovative programming work that's been led by Charles Mots at DPS, as well as Dr. Gary Junker, who we'll hear more from in a little bit, and several of their colleagues. So next slide. And so bringing this home into North Carolina, what we've seen and what we've known for quite some time, as I mentioned, a much higher proportion of individuals, right, in these settings that have mental health disorders and substance use disorders, but they've also seen that growing over time in North Carolina. And not only do we know that there are a much higher proportion of individuals with those disorders that are in our justice systems, that once they're in those systems, and particularly in a prison setting, there's an overrepresentation of individuals with mental illness in restrictive housing or solitary confinement settings. And we've known for a really, really long time, right, that there are several negative outcomes that have been shown time and time again to be associated with being in a restrictive housing or solitary confinement type of setting, right? So increased depressive symptoms, increased anxiety, psychiatric distress, increased prevalence of self-harm and self-injury and suicidal ideation and other factors like that. Next slide. And so the prison system in North Carolina has and is continuing to make some changes to increase behavioral health clinical resources and integrate kind of several other innovative practices to kind of address this and to kind of take a look at this. And so one of these innovative practices are these therapeutic diversion units. And so what these are dedicated treatment units that are serving as diversionary programs for persons with mental illness to, again, divert them from a restrictive housing assignment. And the purpose of these programs is they allow individuals to receive kind of tailored therapeutic treatment, with the ultimate goal of then moving people into a less restrictive environment as in prison, and then eventually, obviously, into the community as soon as possible. And so, as you can see listed here, there are the 4 kind of goals that are laid out for these therapeutic diversion units. Again, overall, the prison system is trying to decrease the population of persons with mental health disorders assigned to restrictive housing. Hopefully through that, improving mental health through these treatment units, decreasing the incidence of violence and self-injury and self-harm and suicidal ideation, and ideally, right, building self-efficacy and skills that can be taken with individuals as they transition to, again, less restrictive environments and into the community. Okay, next slide. So this is a really kind of brief overview and outline of what these units entail. And Charles Mots and Dr. Junker just published actually a really nice study, which is right under that photo you can see listed there. And I'm sure that can be sent to anyone that's interested, that really kind of detail more specifically how these units came to be, how they operate, kind of what they're seeing from these units. But just briefly, generally people are in them for 6 to 12 months in the program. There is like an evidence-based core to all of it related to interactive journaling and other kind of group therapy. And then there's also an individualized approach that involves psychiatric medication management if that's needed, psychotherapy, and other things like that. As people progress through the program, there are increasing incentives and there are decreasing use of restraints and increasingly moving people again to a less restrictive environment. And that again takes place over a 6 to 12 month programming period. Okay, next slide. And so where we came in is we collaborated with DPS to do kind of an outside evaluation of this program. And so what we wanted to do is we wanted to look at how this program was operating and what kinds of outcomes were being seen from the program in terms of disciplinary infractions, mental health admissions or kind of mental health crisis events in prison, self-injury and suicidal behaviors being seen. And so the way we set this up is we wanted to look at, well, what happens when people are in these programs as compared to if they were going to be in the alternative of restrictive housing? What do we see in terms of these outcomes? And then once they're released from the program, are any benefits sustained as they're released into the general prison population? And how does that compare if you were to come out of the alternative of a restrictive housing assignment? What would you see as people are released back into a general prison population? So both looking at the during kind of program effects and then what happens kind of after. So next slide. So what we found, these are some of our kind of big picture estimates, and we can share this study if anyone is interested in more of the details. The green bars represent kind of the extent to which we're seeing these behaviors in a restrictive housing setting. Those kind of bluish, darker teal bars are what's being seen in that therapeutic diversion unit or that TDU setting. What we have on the left is what we're seeing in terms of infractions. So any infractions, and then we broke it out by specific types of infractions. So your A-level infractions are like your most severe. Those are things like assaults on an inmate or a staff member. And then it goes down to a C-level infraction, which are your less severe offenses, which are things like property of theft. And as you can see, what we saw overall is when people are in these programs, we see a several-fold decrease in terms of the infractions that are happening, as well as a several-fold decrease in terms of mental health crisis events and self-injury related behaviors. Next slide. So overall, we did see that this population was a population with a sustained kind of high level of mental health need. They were also a population that had been circulating kind of in and out of restrictive housing very frequently and had very long stays. And the TDU did seem to serve as a way to divert them from that and to promote some of these more positive health outcomes. We've seen some preliminary studies being done in New York and Florida and others where they're doing similar programs, although a little bit different, that are also seeing some positive, similar kind of health outcomes. So I think the evidence base is starting to build a bit more for these programs, not only in North Carolina, but elsewhere. Next slide. And then, as I mentioned, we are working on a study right now, hopefully will be released very soon, looking at what happens when people come out. Do we see some sort of a sustained effect of having these programs in prison settings? And yes, for many of the outcomes there is, right? We do see that people that come out are much quicker or much slower, not as quick as those coming out of restrictive housing to have subsequent infractions or to circulate into restrictive housing as quickly as those coming out of a restrictive housing environment. Some of the self-harm outcomes don't seem to be as strongly preserved. And so we talked there a little bit about maybe there's needs for some additional supports in some of these other areas related to the intensive mental health treatment that individuals are getting. So many of the outcomes, yes, benefits are sustained and some a little bit less so. We're continuing to work with DPS to look at some of their other diversionary programming in the prison setting as well. And that should be coming out as soon as we work through that. All right, next slide. The last thing I'll just mention briefly is our third bucket kind of on this sequential intercept model. This is work that we're just now kind of getting ready to start and are really looking forward to. And so this is, again, much further up and related to pre-arrest diversion programming. All right, so last slide. And so as many of you probably know, through the Opioid and Substance Use Action Plan data dashboard, right, that we have, it's documented what counties are doing in terms of pre-arrest diversion programming. If they have some sort of innovative model or lead program or something in place related to pre-arrest diversion programming. And so we know we have colleagues and friends at Duke that are doing a really nice job right now, taking a deep dive and looking at some of these lead programs that are happening across the state. And so where we're starting to do some work is we're knowing that, or we know from talking to partners that a lot of other colleagues are doing kind of innovative pre-arrest diversion programming. And so we're going to be doing an environmental scan of this across the state to see if we can get some more details and learn from each other on what's happening across the state. And again, take some deeper looks in terms of evaluating these programs to see if we can share practices across the state about what might be working best to do some of this diversionary program prior to arrest. So if you have one of those programs in place, or if you're interested in this work, certainly please do reach out to us. We're looking to team up with others to kind of take a deeper look at some of these, and again, to disseminate this work across the state. So that is all I have. I think I'll turn it over to Amanda.
Thanks so much, Becky. We have one question in the chat for you. It is, how common are therapeutic diversion units in North Carolina? In facilities where they exist, are they able to serve everyone who needs it?
Yeah, and so I'll take this, and then Dr. Junker, definitely feel free to chime in since you know this much more intimately than I do. So my understanding is there's 6 or 7 current TDU programs operating, and that people do, it's not just limited to those who are in a prison wherein one is operating, that they will in fact move people from other locations to come participate in one. I don't know, Dr. Junker, if you have anything else you wanted to add.
Right, thank you. Good question, and the answer is no, there are not enough beds in the therapeutic diversion units to manage all of the offenders with a mental illness. Not all of them with a serious mental illness, but there are not enough beds. But we do have other options available, and we're looking at certainly broadening the program to be able to pull additional individuals out of restrictive housing. We were moving along that path pre-pandemic and kind of had some interruption, and we're moving toward expanding options currently. But thank you for that question.
Great, thanks so much. Our next question is, how does DPS determine which individuals would be admitted or diverted to TDUs instead of restrictive housing? How are individuals selected for the TDU program?
Do you want to take that, Dr. Junker? You're much more involved, or I'm happy to take it.
Sure.
Yeah.
Sure, thank you. And I would really refer you to the reference in the slide. We have a very extensive article, part of the International Corrections and Prisons Association Advancing Corrections article to review that. But in short, it is based largely upon the length of time an individual has been in restrictive housing. We also have tried to target individuals who are experiencing a greater level of distress or higher levels of mental illness. And lastly, those that are nearing release to the community, we really recognize the need to transition them out of restrictive housing before releasing back to their home. Thank you.
Thanks so much, Dr. Junker. We are at time for this section, so I'll go ahead and pass it back to Margaret to introduce our next speakers.
Thanks so much, Amanda. And so this person has, I'm just going to give it over to Joe, but one of the next speakers already made himself known. Good morning, Dr. Junker. It's good to see you. I'll hand it over to Joe to give some more formal introductions.
Thank you, Margaret. Good morning, everybody. I'm Joe Prater. It's my pleasure to introduce the next topic, the North Carolina Department of Public Safety's medication-assisted treatment in prisons pilot project. Presenting on this topic are three excellent presenters, individuals we're familiar with as they're all very active participants with OPDAAC. We have Dr. Gary Junker, who you've heard from just now, Director of Health and Wellness Services with the North Carolina Department of Public Safety with the prison system. Dr. Suchin Shukla with the Mountain Area Education Center, and Dr. Evan Ashkin with the formerly incarcerated transition or FIT program in the UNC School of Medicine. Dr. Junker, first I want to thank you and your colleagues for what you do for our justice-involved population in our state, particularly we've already heard about the therapeutic diversion units, and for this exciting program, I believe, that we're going to hear about this morning, the introduction of medication-assisted treatment in our state's prison system. Hopefully we'll have some questions at the end. So Dr. Junker, I'll hand it off to you and ask that you begin.
Great. Thank you very much, Joe. And again, good morning, everyone. Yeah, we're very excited to be here to be able to present some initial materials on our medicated assisted treatment program within prisons, a pilot program. I want to recognize North Carolina Department of Health and Human Services and Deputy Secretary Nicole Sullivan for facilitating the funding for this project. And certainly also our partners in community corrections, and our whole health and wellness team has been very active in this program. And certainly our partners and our collaboration with the Mountain Area Health Education Center, MAHEC, and the formerly incarcerated transition program that you'll be hearing from today as well. Again, just an excellent partnership, and we're very excited about introducing medicated assisted treatment into these pilot minimum security facilities and looking for expansion opportunities in the future, certainly. We're going to present kind of a brief overview of the program. I'll be coming back on toward the latter part of our slide presentation to talk about a few topics regarding the kind of institution, correction, and facility specific areas. But with that, I will turn it over to Dr. Shukla, and he'll take us through the first portion of the presentation. Thank you, everyone.
Thanks, Dr. Junker. And Sarah, you can go to the next slide, please. Great. So I'm going to start with some sort of basic overview of medication for addiction treatment, or sometimes we refer to as medication for opioid use disorder, and how it pertains specifically to justice system settings. And so as Becky showed in a couple different ways, substance use disorders are very prevalent in the criminal justice involved population, and it drives both violent and nonviolent criminal activity. A lot of times we think of just drug charges and drug related crimes as the key indicator of the level of substance use and how that interacts with the justice system, but it actually interacts with non-drug related charges in a variety of ways. And so as Becky showed, the majority of folks who are incarcerated in America have substance use disorders, and that is the same in North Carolina. But nationwide, especially in the United States, treatment is often scant and not particularly focused on the most evidence-based interventions. And so though the statistics shows that over 50% of patients who are incarcerated receive treatment, most of that is consists of self-help or peer counseling groups. And I don't want to disparage those treatment modalities, but they aren't the most evidence-based at preventing what Becky previously showed as this high rate of overdose after release. And then even that level of treatment really decreases after release as folks are struggling to readjust to life outside of prison. Next slide, please. So even those programs that are rare and that do provide treatment inside jails or prisons often don't have great transition services or partnerships, as we have here with DPS, MAHEC, and UNC FIT, to provide continued care after people leave prisons. And withdrawing from medication for opioid use disorder can be a pretty challenging experience for folks and can cause withdrawals. So it's really important to recognize that transition and reentry into the community, whether meds are involved or not, is a particularly important moment to improve outcomes after release. Though people who do have justice involvement do have higher rates of receiving treatment compared to the general population with those with substance use disorders, that treatment often does not involve the medication, which is the most effective at reducing overdose rates as well as HIV and Hep C transmission. So again, treatment is a good thing, but we always want to be specific and make sure it's the most evidence-based and most effective. Next slide. So I won't repeat some of this that Becky reviewed, but we do have great local state data showing the overdose rates are terribly high for people in the immediate period after release. And this whole context of the interaction between criminal justice system, substance use, and the healthcare system really ends with these three boxes that being incarcerated can interrupt treatment for those who are on treatment before incarceration. That period of time after release is particularly fraught and dangerous, and MAT is a great solution. And so that leads us to our project. Next slide, please. And this is just some specifics on that data. As Becky pointed out, it's those first few weeks where the rates of death are the highest, not only from overdose, things like suicide and other types of violence are also contributors to that higher death rate, but the majority of it is through overdose. Next slide, please. So the alternative, of course, is treatment. And again, specifically treatment with medication for addiction treatment. Buprenorphine, methadone are the most effective, and naltrexone, otherwise known as Vivitrol, are all three FDA-approved medications that are very effective at improving outcomes and reducing death for people with opioid use disorder. And so the slide speaks for itself. The cheapest and most cost-effective treatments for folks with opioid use disorder is medication and not incarceration. Simple to say out loud, I know, for the folks who are working in the criminal justice system to keep our communities safe, but definitely a goal we can work towards. But not only is it cheaper than incarceration, but treatment with medication is actually cost savings, in that every dollar we spend on addiction treatment reduces rates of spending on things like drug-related crime costs, criminal justice system costs like judges, courts, lawyers, and then the actual costs related to crimes themselves like theft. So if you add in the healthcare costs such as ER visits and EMS rides and HIV and Hep C treatment, that number goes up to $8 to $10 saved for every dollar invested. So, and then the non-economic benefits from doing this is reduced rates of recidivism. So that can mean reincarceration, parole violations, criminal activity. But as Becky was showing, some of these interventions, such as the therapeutic diversion units, but also with MAT, you see reduced rates of violence and suicide and self-harm within jails and prisons. Some of this data is a little softer than what Becky was showing from their great work, but you know, there remains more research to be done to show the effect of treatments with medications on these outcomes. Next slide, please. And I sort of view that medication's most significant effect is on not only on overdose rates, but continued substance use as well as HIV and Hep C transmission. But that overdose reduction, especially mortality reduction, up to 75% less likely to die than those not receiving medication. That's a very powerful thing we can do in healthcare. As a family doc who does a variety of healthcare activities, I treat HIV, I treat Hep C. Treating medication, treating opioid use disorder with medications is one of the most significant and effective ways to improve health for our community. So I'm really honored to be doing this work alongside my partners here. Next slide, please. So this is some specific data, and we have references that are probably in the notes section of the slide, so I can send those out. It's not on the slide itself here, but there's some specific studies looking at medication for opioid use disorder in criminal justice settings. So Rhode Island, a smaller state where the jail and prison system is integrated because it's basically a one county state, a very small state. They saw within a year of providing this medication in their jail and prison systems, they saw a 61% reduction in post-correctional overdose death. And in some European countries, such as the UK, they found similar reductions in mortality and specifically overdose death in the more immediate period after release. And then in Australia, you can see a similarly significant reduction in death related to implementation of these programs. So, you know, this work is not being done in a vacuum. We're lucky that we have these other innovators who have come before us to provide these services to show how effective it is at improving health. Next slide. So, and Dr. Junker, I forget what slide you're coming in on, so somebody can, or actually I think Dr. Ashkin, you're gonna take over for the fit part. So please interrupt me if I'm going too long, but I'm gonna give a few small details here of what our pilot entails. You know, the need in the prison population and as well as the jail population greatly exceeds our ability to serve them. And this is a pilot, and it's called a pilot for a reason. So it is limited to 45 individuals. DPS has already had a program for some time now, a couple of years, for pregnant individuals at NCCIW to provide them with MAT during their prenatal care. And so what's new with this program is focused on non-pregnant women and of course men who are incarcerated in the in North Carolina prisons. And we identify them through, I think a next slide explains how we identify them, but the goal is to provide them with medication for opioid use disorder within the first months of their expected release date, and then connect them to the FIT program, formerly Incarcerated Transition Program, to improve their reentry support services to make sure that treatment continues without any gaps in care from that critical period after release from prison before they can establish it with a community clinic, oftentimes a federally qualified health center, since a lot of these folks have a barrier of finding insurance coverage or Medicaid coverage. Next slide, please. So the top bullets there, the 3 facilities where we will be piloting this program. And Dr. Junker can maybe speak more to this, but these 3 facilities are reentry facilities. So they're specific to certain incarcerated individuals who are close enough to their release time where they can do things like work release programs and other supports in that year or two before release to prepare them for life outside of prison. And then I'll leave it to Dr. Ashkin to talk about the FIT program, but MAHEC's role, we're based out of Asheville in the western part of the state. Our role in this is to provide the diagnosis of opioid use disorder through telehealth services to these individuals in the facilities, and to oversee the treatment, implementation, medication initiation and dosing changes that are needed while folks are in prison, and then kind of make sure that they're ready to receive a prescription on release and connect with their FQHC with support from FIT. Next slide. This is a map, small on my screen, so hopefully you guys have bigger laptops than I have, but it explains the counties where the FIT program is active and has community health workers who assist with patients leaving prisons currently. You can see MAHEC's out west. On my screen kind of blue, the three facilities in Orange and Wake counties. And then you can see some of the other FIT counties where we expect to expand. But then the red triangles show some of those counties with the highest rates of overdose hospitalizations and ER visits in the red and yellow. So some of this is kind of integrating where services are available in the outpatient setting, of course, where facilities are, where we can do reentry work, and then lastly, which counties are at some of those highest needs. When people leave prison, they often have a home plan that involves which county they're being released to. And, if they're arriving in a county with high rates of substance use and overdose, that puts them at particular risk. So we want to be intentional about how we're designing this pilot, and we have been. Next slide, please. Excuse me. So we're starting this with a staggered start in the three facilities, and because the women's prison has already had some great success and experience with the prenatal program, we've started there so far, and then we'll be continuing on to Orange and Wake, which are male facilities and smaller, and so that's proceeding along. Next slide, please. I won't go too much into the basic science of the meds, and I'm pretty sure I've talked about it at a previous OPDAAC if you've heard me before. And if folks have questions about how these meds work, I'm happy to refer people to resources of things they can read online. But for this pilot, because of the nature of methadone, we're not planning on using it. It requires a certain level of implementation that required a level of resource we didn't think we had for this project. And also, oftentimes it's hard to continue methadone in the outpatient setting because of a lack of access. And buprenorphine is in some ways more available because a doc like me, a family doc working in a community clinic, can prescribe this. So we really focused on buprenorphine, which will primarily be provided in the combo product. That's a buprenorphine naloxone form in a sublingual administration. This will be done through daily dosing by a medical worker, a healthcare worker, with observation from the custody staff. And for some folks, if they agree to it, they will be getting the injectable version of buprenorphine after they titrate up on their sublingual medication. And so the FDA indications for this is you have to do 7 days at least of the sublingual before you can start the injection. But the injection is great because then you don't have to come every day if you're still incarcerated. And then if you're released and you have to get your ID, you have to get your transportation, your housing straightened out on release, that buys some time because that injection is given every 30 days. And so our goal, ideally, will be to start folks on sublingual buprenorphine, get them on the right dose so they're not having the cravings that are associated with substance use disorders, and then convert them to the injection, and then they're good to go until they can land in their outpatient clinic. Some folks who may be interested will have the opportunity to also use Vivitrol, is the brand name, and the generic is naltrexone injectable. That's also a once-a-month injection. That is not a controlled substance, unlike buprenorphine, and so does not require the same level of directly observed therapy and custody staff supervision, though when you're incarcerated, custody staff is often involved in a lot of your actions. And then everyone, even folks who may not even want medication but are involved in our program, will have harm reduction counseling, which includes how to use naloxone, and they'll get a naloxone kit on release to take with them. Next slide, please. This is a basic workflow of how the protocol will work for folks involved in the program. And so that participant assessment and selection starts with chart reviews by myself and other medical providers to see who are folks who may have indications of an opioid use disorder. I'm, as a person who has mostly worked in the outpatient setting, I was surprised at the level of care folks incarcerated get, when oftentimes they didn't get much care prior to incarceration. And so they get a lot of assessments and intakes by medical and behavioral health staff that can help us understand for this pilot who would be potentially eligible for it. So then they'll have an intake, which involves an informed consent, the best you can do in incarcerated settings, so they understand how the medications work, the benefits and potential risks, what's involved with taking the meds while they're in the prison, as well as what does it look like when they're released. And then treatment initiation and maintenance is pretty straightforward. We do it routinely in the outpatient setting all around the country, all around the world, really. And so it's just starting a low dose of the medication and then titrating up until folks are not having cravings. We anticipate that these individuals will not be having active use while incarcerated, so they won't have to worry about withdrawal symptoms or precipitated withdrawal from starting the meds. And so really the goal here is to get to a dose where they're feeling no side effects and feeling no cravings, particularly in preparation for when they leave prison. And there are more triggers to cause people to have cravings for substance use. So while that medication piece is going on before release, they're having engagement both with DPS staff as well as the FIT team, sometimes in person, sometimes through telehealth interactions, to make sure that this home plan is solidified, particularly how they're going to connect to a community clinic to continue their meds and not have days or weeks where they don't have their meds. And FIT will support that, as they already do for folks leaving prisons. Next slide. I won't talk through this slide in depth because I'm sure I'm already over time, but and I know that folks will have access to the slides within the week. But you can see the top upside down triangle is some of the criteria we would use initially before even meeting the patient to indicate that they may have opioid use disorder. And so some of these boxes refer to the intake screenings they get at various times during their incarceration. Some of it is programs that are focused on substance use. And then some of it's actually related to charges that got them incarcerated or disciplinary actions taken. And then everyone basically will have a chart review to make sure that this makes sense, to then offer them the opportunity to have a telehealth visit with a medical provider who's an addiction specialist. And they'll sign their consent if they get answered any questions they may have. And as long as they have no medical and behavioral contraindications, which there are pretty much none when it comes to buprenorphine, they can start the treatment process. Next slide, please. Excuse me. And I think, Dr. Ashkin, this is where you kick in.
Yes, great. Thanks, Dr. Shukla. And congrats on the addition to your family. So our formerly incarcerated transition program will step in at this point once the patient has been screened and had their initial medical evaluation, and discuss participating in our program. As many of you may know, our program uses community health workers that are all have histories of incarceration themselves, and we'll talk to the prospective clients about participation, about what it means to be in the FIT program, benefits of this kind of support post-release. As many of us are aware, all the best laid plans often fall to pieces quickly upon release with all the other urgent needs that people have with housing, food, employment, post-release supervision, and so on. So we will then try to assess someone's desire to participate in our programs, which are from the map you saw before in 5 counties in the state. And then if all looks good and people want to continue, we will then notify DPS and our colleagues in the pilot to go ahead with the process. Next slide, please. So what does that mean to be in our program? So we have one of our FIT community health workers is dedicated to this initial screening process and working with people while they are still incarcerated in the prison system. And then they will be turning over that client to the community health worker in the FIT program in our 5 locations. And our goal is obviously getting people a warm handoff into competent, comprehensive care. However, it is also having a comprehensive reentry plan to build on what has been done prior to release to make sure people do have stable housing, food, help with transportation, and all the myriad barriers that we know people face. And then, our community health workers are embedded into these clinics. So it's not just a referral, they actually go with patients to their visits. They, if the client is in agreement, will actually be with them in the room with the provider, help make sure that they're able to actualize the plan that is agreed upon with their provider, help them get their medications. And we do have funding in this pilot, as we do in the regular FIT program, to help with the costs of those visits and to get their medications for opioid use disorder going forward. We, as you saw on the map, we are looking to find other clinics where we don't have FIT programs around the state, so we can enroll more folks, and hoping to solidify some of those collaborations in the near future. And now I will turn it back over to Dr. Junker.
Thank you, Dr. Ashkin. Appreciate that. Again, I'll just briefly go through this slide and then a couple of other slides with comments, but certainly the MAT program it's critical that our facility staff are buy into the model. Certainly there are cultural obstacles that we have to overcome through education. But the slide you see here are different roles from the different players. On the far right, you see the support staff within our correctional facilities. Certainly important that they recognize the ability to make referrals to the program. They will be involved in the transport of offenders to telehealth appointments internally. Supporting the medical staff when medication is being administered. Our correction officers certainly involved in that process. And certainly our social work staff, again, as Dr. Shukla mentioned earlier, there are a number of behavioral health and social work services available within prisons, and our social work staff will be involved in that process of developing a home plan and transitioning to the community. We certainly know that transportation, housing, and employment are 3 critical variables for individuals to succeed post incarceration. And so coupled with the substance use disorder, certainly challenges that exist. Next slide, please. So some of the biases or myths that many believe is that there will be an increased diversion within a facility if the introduction of a MAT program, that there will be a less safe environment within the facility because of MAT and different medications being administered through an MAT program. And a third common bias is that, well, all the offenders who have a substance use problem, maybe others, they'll all want to participate in the program to be able to receive medication. Next slide, please. So actually research in other parts of the country and internationally have observed actually that there are reduced drug seeking and diversion activities within prison populations when an MAT program is initiated, that there actually isn't pressure within the prison system, the social structure, as far as individuals, again, trying to gain access to the program. Conflicts amongst inmates, the offenders are reduced in some studies that we looked at. and that overall violence and security and diversion regarding medication is actually reduced. Certainly contrary to what people believe, that the participants in an MAT program are actually easier to handle. Again, they're not engaging in that underground activity trying to seek out medication. And certainly that there isn't evidence that individuals try to enter into the program even if they aren't appropriate or drug-seeking type of behavior. As Dr. Shukla mentioned, we have a very stringent, structured process of reviewing the patient's background and history to be able to find the candidates that are likely to really benefit from the program. Two other points I want to mention before I open it up for questions. One is Dr. Shukla mentioned about MAT and efficacy of MAT for reducing overdose and mortality post-release. Within prisons, we have a cognitive behavioral program, our alcohol chemical dependency program. And so with that and with MAT, we very much lean toward a holistic model of treatment. So not one or the other, but both, because certainly individuals need to develop a recovery plan and be able to have in place anticipatory types of triggers that are going to exist in the community to be able to plan and prepare for that. So certainly that holistic model is what we espouse. As well, the question may be raised about number of beds within prison for substance use treatment, and it's far less than what is needed. We've recently initiated and will be continuing to move toward a new program called Recovery Road, in which additional offenders with a substance use history will be engaged in treatment activities, not a formal treatment group type process, but will be introduced to recovery throughout the term of their incarceration. Dr. Piper, our behavioral health director, and Ren Rivenbark, our chief over alcohol chemical dependency, are instrumental in creating that recovery road model. And one more thing you may be interested in, we have 2 alcohol chemical dependency programs in the community for probationers, one at the Black Mountain Treatment Facility for women, and also one in Goldsboro at the DART Center, which is for males. And we recently have worked with Department of Health and Human Services here in North Carolina, Dr. Carrie Brown, and we'll be initiating in 2022, providing naloxone to individuals when they leave those programs, when they finish treatment. So they'll receive a Narcan kit it'll be voluntary, but that will be available to them. And we really hope that that targeted audience, that will help for them, their peer group, to be able to reduce overdose potential. So again, thank you for your time. We certainly appreciate your attention, and very excited about these programs that we're initiating within prisons. And with that, Joe, I'll turn it back over to you.
Thank you, Dr. Junker, and thank you, gentlemen, for your presentation. This is very exciting to me, and we look forward to seeing its progress down the road. We're very limited in our time right now, unfortunately, and we've gotten some really good questions. Maybe we can address these maybe at the end or in another way a little later, but let me hit this one. Could you speak to the differences, if any, between outcomes and effects for MAT with opioid agonist agents versus other agents, for example, naltrexone?
That's a great question, Joe. And I know there's some other questions in there, so I'll try to answer in the chat box or in the Q&A. But for your question you just said, Joe, I'm not aware of those studies, particularly in the criminal justice settings. For general participants, when we compare methadone and buprenorphine, the outcomes are pretty much the same, in that about 50% of folks are engaged in care and not using opioids at 6 and 12 months after starting those meds. Whereas naltrexone, the injectable version of naltrexone, that number is about 35% are doing well at 6 and 12 months. And that's specifically because starting naltrexone is a little bit more challenging in the community. You have to be free of opioid use for 7 to 10 days. And even then, initiating that medication can cause symptoms, whereas with buprenorphine methadone, it's a lot easier to start. However, in the criminal justice setting, such as starting meds in prisons or jails, I would anticipate it would be easier to start naltrexone because folks are generally not using substances while incarcerated. So that's why we included it, even though the efficacy is not the same. So great question. Thank you.
Thank you, Dr. Shukla. I think that'd be great if you all could go into the chats and answer those questions, because again, there are some very good questions in there, and I thank everybody for that. Again, gentlemen, thank you for the presentation. Let's move on to the next. It's also my pleasure to introduce the next topic as well. And I need to add that this is, it's reflective of a lot of OPDAAC's work in that we connect the dots with a lot of intersectional things that relate to what we're all about. And so this happens to be one of those and how it connects. And I think it's important that we review those things and examine those things and broaden our view of what OPDAAC is dealing with and working with. Our state's community corrections operations play a vital role in maintaining public safety in our state and for providing rehabilitative support for individuals on probation, parole, and post-release supervision. We've already heard some commentary about what we know about that population as they come out after release, and they are under the supervision of community corrections very often. And so this includes individuals with substance use disorders and with serious and persistent mental illnesses, which, as we know, and as Becky addressed, of course, unfortunately, often intersect with each other. And with that in mind, I'm very pleased that we're able to hear about a community corrections program this morning that specializes in working with probationers with serious and persistent mental illnesses. Presenting on that topic this morning is Dr. Gary Cuddeback with the UNC School of Social Work, who has been working with community corrections to develop this program and train officers in its use. Dr. Cuddeback, I want to welcome you this morning to our group and thank you for what you do with assisting community corrections with this program. We look forward to your presentation, so let's get started. The virtual floor is yours, sir.
Thank you so much, and thanks for that warm introduction. I am delighted to be here this morning with everybody and excited to talk about this topic, which, as Joe said, I've been working on for a number of years with a number of terrific folks, both from the Department of Public Safety and at UNC and elsewhere. Next slide, please. So I'll talk a little bit about, although I won't have to talk a lot about individuals with severe and persistent mental illness, defining what we're focused on with our specialty mental health probation pilot and our training of officers. Talk a little bit about background and prevalence, which, and this is a nice dovetail to what we've heard from the prior two presentations, sort of close the loop on this population that's on probation in terms of their background and prevalence and kind of intersection with different parts of the criminal justice system. And then we'll talk about the complex needs of justice-involved people with SPMI. And then I'll talk about specialty mental health probation and those pilots. And hopefully at the very end, we'll have time for questions and answers. So next slide, please. So what we're focused on with the specialty mental health probation program are really folks with severe and persistent mental illnesses, schizophrenia, schizoaffective, bipolar disorder, delusional disorders, and other psychoses, and really those who are chronically disabled. And there's some bullet points here. And in my career, I've done a lot of work with administrative data, which it's often hard to define severe and persistent. But these are generally individuals who are in and out of state hospitals. They're in and out of local hospitals, in and out of our criminal justice system, as we know, and are really have difficulty functioning independently in the community. And then these are folks who've had these disorders for quite some time, sometimes as evidenced by supplemental security income or social security disability income. And as we all know, those programs take quite a while to get folks enrolled. So if you see evidence of someone having one of those, it's clear that the duration of these illnesses has lasted for a while. Okay, next slide, please. So as we all know, the public mental health system has really shrunk in the last 50 or so years, right? Most of our individuals with severe and persistent mental illnesses were in state hospitals where, if you think about it, care and treatment were together, right? Say what you will about the quality of that care and quality of that treatment. However, care and treatment were together. Now with folks with severe and persistent mental illness, particularly those who are justice involved, diffused among many different public sectors. They're left to navigate these different public service sector systems, each with their own funding streams, their own eligibility criteria, all by themselves. And a good example of why we need programs like the FIT program. Unfortunately, the criminal justice system, when I go to do mental health services research, and this characterizes our other presentations here today, I often go to the criminal justice system where there just are many, many individuals with severe and persistent mental illnesses. And I'll talk about our specialty mental health probation program and studies in that context. If you think about it, the fates of individuals with severe and persistent mental illness are often closely intertwined inadvertently with criminal justice policies. If you pass a no loitering or solicitation ordinance on Franklin Street or somewhere else, it's most impactful and most quickly impactful for individuals who are homeless, substance use issues, and serious and persistent mental illnesses. And also, unfortunately, the criminal justice system is, as we all know, the place of last resort for individuals with severe and persistent mental illness who are not maintaining well in the community. And it's also a public health outpost. As we all know, it's oftentimes someone with severe and persistent mental illnesses, it's their best and first chance to get diagnosed with either a chronic physical health problem or a serious mental illness somewhere in the justice system. It's unfortunate and unfortunately a reality for many. Okay, next slide. So on any given day, and these figures probably need to be updated a little, but on any given day, we have about 37,000 individuals across our network of state hospitals in the country. Juxtapose that with over 250,000 in prisons, 130,000 in jails, and over 1 million on probation and parole community supervision arrangements. The red oval is around jails because we all know jails are short-term, quick turnaround facilities. Of the 3,400 jails across our country, approximately, there's about 14 million jail admissions, and I would say about 1 million of those involve individuals with severe and persistent mental illnesses. And if you think about, again, the sequential intercept model or intervention points along the criminal justice continuum, we have interventions now, and it speaks to how law enforcement, how criminal justice has taken on a role of being the custodians of individuals with severe and persistent mental illness and really having to respond to the needs of that population. We have interventions for police. We have specialty mental health courts. We have interventions in jail with screening and treatment. We have interventions to try to facilitate exit and release from jail. As we've learned today, we have programs in prisons and we have programs in probation and parole. Next slide, please. And let's see, this may be one of those delayed, so go ahead and hit, there we go. So as we all know, and we'll focus now on mental illness and community corrections, there's lots of individuals, maybe up to 5 million on community supervision arrangements. And if you think about best estimates of how many of those have a mental illness, maybe 16 to 27%, probably conservative actually. So the majority of folks, the point here, who are in the justice system who have mental illnesses are clearly on probation and parole, just because of the volume of the number of individuals on probation and parole across the country. So this presents a number of challenges. So probation officers have limited and insufficient resources available in the community. Now programs like FIT and other programs are trying to address that, but in general, there are some issues with accessing resources. Often officers aren't well equipped or well trained to understand and address the unique needs of individuals with severe and persistent mental illness. Officers who have high caseloads, maybe a punishment versus treatment orientation, and then individuals with SMI who are involved with probation often have greater difficulty meeting the terms of supervision. They have higher rates of probation violations and recidivism. As we've heard today, they have lots of co-occurring, comorbid, complex problems. Let's see, I got distracted by a question. It's blocking my slide actually. So lack of medication adherence and then lack of health insurance. There we go. So all of these complexities that probation officers are having to deal with. All right, next slide. All right, and as we all know, individuals living with severe and persistent mental illness in general have lots of complex needs, social isolation, homelessness, substance use, unemployment, chronic physical health problems. I think when you layer on the justice involvement, not in a causal inferential fashion, but when you layer on involvement with the justice system, these needs are exacerbated. So next slide, please. So here's data from a study I did years ago. This compares general population. This comes from medical expenditure panel survey data. That's the yellow bar. Green bar are individuals with severe mental illness who are not have justice involvement, and the red bar are justice involved individuals with SPMI. And these are just 4 areas here, although there are 10 ICD-10 classifications now. I just picked 4 of these. You can see across the board, when you layer on that justice involvement, things become more complex. So more likely to have infectious diseases, more likely to have blood disorders, more likely to have skin disorders, more likely to have injuries. And if you think from a public health perspective, these are the types of things that you want treated, right? After release from jail, for example, someone starts maybe a treatment for tuberculosis, but it gets interrupted by a release. Can we have continuity of care from jail to public health? So this just highlights again some of the complexity and physical health problems that individuals experience. These data come at a study I worked on years ago at King County, and basically compares these 3 populations. King County, Seattle, that is. Okay, next slide. So I recently completed a randomized controlled trial here in the state of North Carolina about specialty mental health probation. Data analysis ongoing, but here's some preliminary results about trauma. And trauma is something that individuals involved in the justice system generally experience. When you layer on the severe and persistent mental illness, that group is also at an elevated risk for trauma. So here was a sample of 204 probationers that we enrolled in our study. And yellow bar are the entire population. Red bar are those who met diagnostic criteria for PTSD. And then the green bar are those who did not meet criteria for PTSD. But you can see if we just focus on the yellow bar, 80% of our sample of 204 experienced a physical assault, 60% experienced an assault with a weapon, 50%, and this is men and women, experienced a sexual assault, almost 40% a life-threatening illness or injury, and 90% of the sample experienced the interpersonal traumatic event. So this has implications for correctional officers in prison, probation officers, jail staff, and so forth, just the extremely high rates of trauma. Okay, next slide. All right, service needs, same sample. So we asked, sorry, again, I'm distracted by the chat here, what their service needs were. So we asked up to 18 different services. So the red bar really will focus on that. So of the 204, these are individuals on probation. 60% needed their basic needs met, 70% had medical care needs, 70% have dental care needs, 70% had outpatient mental health, 70% medication needs. So one take home here is people on probation, in addition to meeting the requirements of probation and being compliant with that system, they've got all these basic needs that make it difficult for them to do many of the daily activities of living, but also meet probation requirements. Next slide. Here's another example. 70% of our sample didn't have a valid driver's license. So getting transportation is often a big barrier, as we all know. 60% did not own or rent their own home or apartment. So a lot of couch surfing and transitory living. Almost 70% were not Medicaid enrolled. And as we all know, Medicaid is often the gateway to accessing services for folks. So without this, it is a significant challenge for providers, community mental health providers, and for these individuals. Only less than 50% were currently receiving any mental health services, and almost 50% had a prior probation. So these are individuals with extensive justice involvement history. Okay, so there's a profile of needs among this high-risk group. Next slide. So this is work I did years ago, just looking at criminogenic risks among probationers. As you all know, criminologists, sociologists think about factors related to criminal activity in a somewhat different way. And you'll notice if you think about criminogenic risks, there's 8 of those, and mental illness is not one of them, right? Now, when someone gets on probation, and this is true for prisons as well, in North Carolina, they fill out a self-assessment, and there's questions about substance use, antisocial personality traits, dysfunctional family history, self-control, antisocial values. So I looked at the self-report from these probationers across the state and compared individuals who had evidence of SMI versus those without SMI. And you can see across the board, individuals with severe mental illness have elevated criminogenic risks. So this is a synergy between mental illness and these criminogenic risks in the context of a probation officer. These individuals then become more complex, have greater supervision needs, take more time and energy, and so forth. So again, the synergy between mental illness and criminogenic risk. Okay, next slide, please. Let's see, I accidentally had that in twice. Let's advance. Okay. So one of the things my team and I have been doing in concert with the Department of Public Safety is we've created statewide mental health training modules. We have 9 of these now, so the most recent 3 are not listed. But we are providing in a web-based format state mental health training. So when new officers join community corrections, they go through these modules. And the idea here was just to provide basic information about mental health. So this self-report that I mentioned that all probationers complete is called the Risk and Needs Assessment. So there's a module on using and interpreting answers about the risk and needs assessment. And there's 4 mental health questions on there that individuals on probation self-report. So really, this module, this first one, is focused on helping officers have a conversation with a probationer about the answers to those mental health questions. So one of the questions is, I see or hear things that others don't see or hear. So most officers don't want to address that question. They don't really want to know the truth to that answer, to the answer to that question. So this is a module helping them facilitate a conversation so they can really understand the answers to those questions. We do a Severe Mental Illness 101 webinar, psychiatric medications, post-traumatic stress disorder, personality disorders, traumatic brain injury, talk about crisis response and local services for individuals with mental illness, and then self-care for probation officers. The suicide rate, unfortunately, among this workforce is relatively high compared to other disciplines. So providing the officers with information about vicarious trauma and strategies for looking out for each other, educating themselves, is something that we added to this 6th module. We did a simple pre-post evaluation And we did find that mental health knowledge among officers increased from pre to post, and also perceived stigma towards individuals' mental illness decreased, which is good because there's evidence that the less stigma you have towards someone, the more likely you are to engage and help that individual. So these were positive findings from our simple pre and post test evaluation. Okay, next slide. So here are the partners involved with our specialty mental health probation pilots, which I'll talk about in a moment. We've been working on this since 2011, 2012, really initiated by the Department of Public Safety. School of Social Work at UNC got involved. DHHS was involved, and then Treatment Accountability for Safer Communities were our initial partners in this endeavor. So you'll see on the map there, we started these pilots in 2 counties, Wake County and Sampson County. And then I'll talk about how this evolved. Next slide, please. So really specialty mental health probation, it's not new generally, but it's new to North Carolina. So other parts of the country were doing it. It was new in North Carolina as of 2012. We hadn't had any initiatives like this. So there's evidence that suggests that specialty mental health probation is a promising practice. It improves mental health and some criminal justice outcomes. And there's really 5 elements of a prototypical specialty mental health probation model, which we've replicated here in the state. Designated mental health caseloads. So our probation officers have caseloads made up exclusively of individuals with mental illness. They have a reduced caseload size of about 40 versus 60 to 70, sometimes higher for a standard caseload. They get ongoing mental health training and support. They have enhanced interaction with resource providers, such as programs like FIT or housing or community mental health providers. They also adopt a problem-solving supervision orientation that helps them think through, are there treatment components or treatment options here rather than a criminal justice response. Now, we are very clear as we're working with our officers, who are absolutely terrific, that under no circumstances is this should this compromise the probation officer's primary mission, which is protect the public safety. So we work very closely, and sometimes they need to have a criminal justice response given the circumstances with some of their probationers. 2 other innovative features that we were able to add. We have a licensed clinical social worker that has clinical consultation monthly with all of our probation officers. This is a great feature and credit to the Department of Public Safety for allowing this to happen. But our LCSW, licensed clinical social worker, meets regularly, talks about cases that maybe officers are stuck with, provides recommendations, provides information, explains what different medications are for and what different treatment resources are meant to do. The other innovation is a community stakeholder building meeting. So whenever we launch a new county, we will bring together the MCO, the providers, local criminal justice authorities like police, sheriff, probation officers. We'll get everybody in the same room to introduce the officers and kind of kick off the initiative, with the point that we hope to network, facilitate network between officers and providers to let everybody know that the program is now in their county and get everybody working together, as you've heard all throughout the morning, focused on serving this complex population. Okay, next slide. So a couple of studies now that we've done. We finished a big RCT, a randomized controlled trial. This was an implementation effectiveness study. So we randomly assigned 204, as you saw, individuals on probation to either standard probation or specialty mental health probation. Those results we're working on those now. Recently, I had funded an implementation effectiveness study of combining specialty mental health probation and a supported employment intervention. The unemployment rate among individuals with severe mental illness is extremely high, up to 85%. Many of these individuals want to work, but often are afraid to try if they have Social Security disability income or SSI. And IPS is individual placement support supported employment, which is a specialized employment intervention for individuals with severe mental illness. So we're trying this in Durham County and Wake County, and COVID has delayed a whole lot, but we're up and going, and we've enrolled 15 folks so far, randomly assigned to either regular services associated with specialty probation or IPS plus specialty probation. Next slide, please. So here's where we're at with our specialty mental health probation county. We're in 20 counties across the state. And you can see there are some in each division across the state. Our newest counties are Henderson, Rutherford, Haywood, Jackson, and Macon. So we're out in McDowell County on the western part of the state, and all the way down at the beach in Brunswick County, and everywhere in between. Typically, there's 2 officers and 1 specialty mental health chief in each county. So they make up a small unit. And then they each of the officers supervise up to 40 individuals with severe mental illness. They're screening them for mental illness and basically social determinants of health and criminogenic needs. And there's somewhat of a gatekeeping function to get into the program, because we want to serve those with the most profound mental health needs and comorbid substance use needs. Okay, next slide. So over the last 12 months, COVID notwithstanding, you can see an increasing trend of the number of cases we've added. So back in August 2020, our officers across the state were serving just under 400. Now we're up to 450, and we could probably double the number of our officers, and we would still not meet the demand for the service. But that just shows you the trajectory of enrollment over time. Next slide, please. And as we all know, it's not just about addressing mental illness, right? And researchers have tried to disentangle the extent to which it's mental illness is the root cause of criminal activity versus other factors. And they're not successful, as you can imagine, because it's difficult research to do, lots of confounding variables. But from what limited research there is, given the methodological limitations, mental illness really has a small a part of justice involvement. It's all these other things that go along with mental illness, right? Substance use, lack of social support, isolation, lack of safe and stable housing, lack of employment opportunities, low education, all of these other social determinants of health that really drive a lot of justice involvement. Okay, I think that's the last slide. Yes, thank you.
Thank you, Gary. Appreciate that. That's a great program. I'm glad our folks have been able to hear about today. I know it's been in existence for a while and probably continues to be a work in progress. I've got a question from one individual about whether there appear to be any plans that this might come to Edgecombe or Nash County in the future.
Yeah, that's a great question. My colleagues at Department of Public Safety would like this in all 100 counties. So we're working on it, and we just expanded by 5 counties, and there's plans for further expansion. If it's Edgecombe and Nash in particular, I'm not sure, but if you want to contact me, I can talk more about the expansion plans.
Great. One question I'd like to ask with Facilitator Liberty, you've mentioned probationers. Is this program applied exclusively to probationers, or are there any post-release supervision folks?
Oh yeah, we're focused. Thank you, Joe. We're focused on the post-release folks. So those folks are filling up the officer's caseload. As we all know, those are high-risk, high-need folks who are re-entering the community. Sometimes, after lengthy prison stays, right? So absolutely, those post-release folks are eligible and a focus. Matter of fact, someone coming out of a prison into one of our specialty mental health pilot counties who had a diagnosis in prison or was receiving services automatically gets a specialty mental health probation office. So that's an automatic thing. So our officers are coordinating with prison information system, finding out, if someone's coming out with a diagnosis and so forth.
That's awesome. Thank you for that information. I think that's important for sure. Again, Gary, thank you so much for your presentation. I do appreciate what you are doing with community corrections. It's such an important component of what we do. And thank you for joining us this morning.
You bet. Glad to be here.
Thank you. So Jan, I'm going to hand it over to you for our next topic.
Okay, thank you, Joe. We really wanted to bring you some information about the connection between substance use and traumatic and acquired brain injuries. I am honored to introduce our two speakers, and we'll be sending out their full bios with your packet of information. First, we're going to hear from Dr. Robin Hurley. She's Associate Chief of Staff for Research and Academic Affairs at the Salisbury VA Medical Center and Wake Forest School of Medicine Professor of Psychiatry and Radiology. We also have Beth Overby. She works presently for the Brain Injury Association of North Carolina and with Cook Care Management in the capacity of a case manager. So we are excited to have these two speakers today. And Dr. Hurley, please take us into the presentation.
Okay, next slide, please. Thank you guys so much for having me here today. And it's just amazing what I've heard today in terms of how much the care for those in the criminal justice system has changed since I used to do that work back in the 90s. So I applaud all of those that have given the previous talks, because it's just really amazing how much it's changed since then. Maybe I'm feeling a little old hearing it. First, as a federal employee, I have to put this slide up. I have to say that the views expressed in this session are strictly those of myself. They do not represent policy of the Veterans Health Administration, the Department of Defense, or the United States government. That's one of those things I have to say at every lecture that I give. And the other thing is, for disclosures, my team and our work is funded by the Department of Veterans Affairs and the Department of Defense. Occasionally there's off-label use of medications that I'm asked about, and we do have funding from many pharmaceutical companies in our research institute, but they are totally unrelated to anything I'm going to talk about today. So next slide. So what I was asked to talk to you a little bit about today was the interaction between opiates and opiate use disorder and brain trauma. And there's really multiple levels of complexity with this, and it's very much intertwined. So to sort of get a little bit of a handle on it, and as you heard, I work in academics. And so my work is in neuroanatomy and in matching symptoms to brain anatomy. So I'm going to talk to you a little bit about that today in terms of a little bit behind the whys of why this is such a problem. You heard in the last speaker's talk about the huge numbers of trauma and of substance abuse in this population. So we're going to go through some of the things on the slide in about the next 10 or 15 minutes or so, and hopefully we'll have some time at the end for questions. I do have a video of a case to show you, as you'll see. So opiates impair acute judgment and reaction time. I think everyone on the screen knows this. Opiates can have effects at the time of the physical trauma to the brain. They impact the recovery from physical trauma. Anoxic injury certainly can occur, as we all know, from opiate overdose. And there are compensatory changes that can occur in the brain with long-term addiction. And chronic substance misuse is associated with multiple traumas. And we'll go through a little bit about some of the research in that in just a minute in the next slide. So that's if the opiates are first. Well, what if the trauma happens first and the person has no history of substance misuse until there's a physical trauma, or what we call in the world of VA polytrauma, where it's brain and body that's injured. So we're going to talk a little bit today about the common areas of brain trauma and how that relates to opiate misuse. And we're going to talk about the reward pathways in the brain very briefly, and then the in common areas of those two things with opiate receptors. New physical addictions to opiates can occur with treatment of these terrible traumas. We talk about delays in recovery and readjustment, those occur, and the amplification of neuropsychiatric symptoms if there's an overlay of substance abuse. So all those things happen. I don't know that we're going to get to do anything but touch them lightly in the next few minutes, but there's references at the end to papers for which the audience can take a look after this talk. And then lastly, we're going to end on some encouraging news for the future and a really inspiring veteran story, of which I'll tell you now that I have his written permission to show the video that I'm going to show today. So next slide. There's very little research, which was really interesting to find, as after Janice approached me about doing this talk, I was like, well, what is the most recent, PubMed literature on this? And there's really not a lot out there that's published on the specifics of looking at post-traumatic brain injury and opiates together in the same paper. There's many, many papers looking at them individually, but there's not a lot of work looking at them together. So here's some of the things that I was able to find that were of most interest to me and I thought would be nice facts to share here. And some of it, of course, is common sense, but to see it in writing is one thing. And an example of that we often hear is, we know that, of course, if you're going to jump out of an airplane, you need to wear a parachute. But there are no papers in PubMed stating that if you're going to jump out of an airplane, you better have the parachute on. So some of the things we know as common sense are not always in the medical literature. So let's look at a couple papers. In one recent review, 40% of all entering trauma patients with brain trauma into trauma centers and hospitals were positive for drugs. 42.7% of autopsies from the traumas where folks died in the traumatic event were positive for alcohol or drugs, and 40 to 50% of trauma patients across the whole U.S., if you look at databases, state databases, as opposed to a trauma center study, were positive for alcohol or drugs at the time of the trauma. Motor vehicle accidents, of course, we all know, is a common cause of both body and head trauma. And the risk of being involved in a motor vehicle accident goes up with the use of prescribed opiates. And we now have data to show that, as you see the study mentioned. Interestingly, the risk of MVA culpability goes up, that the accident is deemed, quote, your fault if there's opiates involved. And the use of intoxicating substances really confounds the Glasgow Coma Scale at the time of the trauma evaluation. Obviously, it worsens it if a person's intoxicated. The Glasgow Coma Scale is really the common tool that's used to predict pathways for treatment at the time someone comes in after a concussion or horrible body traumas in an accident. We look at that Glasgow Coma Scale to decide where they go. Do they need intracranial pressure monitoring? Do they need to have induced hypothermia? Do they need to be in a neuro ICU? All of those things can be worsened if there's opiates on board. Next slide. And so we know that in traumatic brain injury, here's some recent stats from TBI. There are 223,000 TBI-related documented hospitalizations and 60,000 TBI-related deaths in the U.S., non-war related. And I'm going to show you some from the wars in Iraq and Afghanistan in just a moment. Of course, our high-risk groups are the elderly, males greater than females, children, veterans, and minorities are all at risk for brain injuries. Common injuries occur with falls, firearms, motor vehicle crashes, assaults, and then, of course, military service-related incidents. Next slide. So within the military-related TBI, for those of you who may have seen this slide before when I have spoken with this group before, the majority of the injuries occurring in our veterans in Iraq and Afghanistan are due to mild brain injuries. We document them as mild, meaning, they had a mild concussion and were able to recover. And fortunately, there were less moderate, severe, and penetrating. And if you look at the bottom graph on the slide, you'll see that as you see it, it trails exactly with the wars. When there was a surge in troops, there were more injuries. When there was a surge in combat, there were more injuries documented. And as the wars tapered off, of course, there were less documented injuries. And we'll talk in just a moment about why this is important to the opiates in just a second. So next slide. So before we get to that, in terms of why that's really important to us, I want to talk a little bit about the anatomy. What you see here, of course, is a very colorful slide looking at the mapping of those memory and emotion tracks in the brain. You know, the brain works as a series of circuits. It's not just one area that does one thing. And so what we're really going to look at in this, rather than all the names of all these brain structures, which is, of course, a lot to do in 10 minutes, we're going to look at colors and where those are on the brain. So the pink parts of the brain are your areas for cognitive function. That's what is impaired in schizophrenics, like you just heard about in the previous talk. The blue areas are inhibition, judgment, mood. The areas that are green are part of the cingulate circuits, which are involved in motivation and ability to understand and to wait for things and not be impulsive, and are tied to chronic pain, which will bring us to the opiates, and are tied to your memory factory as well, which are the areas in gold. So keep in mind where you see the pink, the blue, and the green. Okay, next slide. Okay, so let's look at the reward circuits. One of the things that this group is very much an expert at is knowing that, you know, substance abuse, of course, triggers the reward circuits in the brain, and that trigger to those reward circuits gets amplified by the use of the substances. So the areas to look at on these pictures of the brain, and you see these are sagittal pictures with from the sort of lateral and medial aspects of the brain cortex. And what you see in the colors are places that are yellow, yellowish orange, and orange are the places that are very much tied to the reward circuits of the brain. Now, how many of those same spaces did you just see in the pink, blue, and green on the last slide? They overlap tremendously. So the reward circuits are tied to the circuits for cognition, behavior, motivation. And then if we go to the next slide, what we see are those very same brain circuits have opiate receptor binding. So again, looking at your areas where there are higher opiate receptors, if you look at areas that are orange and red and even some of the yellow, what you see here is those exact same circuits that are cognition, that are motivation, that are mood, that lead to all of those chronic mental illnesses that you heard in the last lecture are tied intimately to the opiate receptors in the brain. So this makes the intertwining of opiate use disorders and mental health symptoms and areas for brain injury all together as really one topic in one point of discussion. So next slide. And to bring it home even further, what we see are the areas that are most commonly injured in brain injuries are exactly these same places we just talked about that are in your cognition, your emotion, your behavior circuits that are tied to reward, that are tied to opiate receptors. We see the most common area for subdural hemorrhages. And on the right, you see example pictures from brains. And on the left, you see the neuroanatomy. And what we see in the middle are the colored areas where these injuries occur. Most common thing to happen are subdurals. They occur around your area for cognition. Your second most common area to be injured in the brain are the tips of the brain where it can hit against the skull when there's a sudden deceleration. And that's where your bruising occurs, you know, where there's a heavy trauma to the brain. For example, in a motor vehicle accident, when the brain hits the side of the car or the framing or the steering wheel, or gets hit with a baseball bat or worse. And then lastly, you see here the circuits that are for that get most injured with diffuse axonal injury. That's in our sudden deceleration injuries, things like motor vehicle accidents or falls from height where there's speed involved, motorcycles, anything for which the brain can get jarred back and forth in the skull. And so all of these areas that are most commonly injured are the areas that directly match to your emotion and memory circuits, and then also match to the reward circuits and to opiates. So if we move on to the next slide. So the symptoms, to bring us back a little bit out of neuroanatomy for just a moment, the symptoms that we see very much comorbid to traumatic brain injury, and you saw some of the epidemiology of that in the last lecture, is depression, anxiety, post-traumatic stress, and substance abuse. Those are all things that we see very much tied to brain injury. You know, if a person has multi-trauma, they're much more likely to have chronic pain. If they have many traumas, they're more likely to be opiate related, as you saw in one of my first slides. And so it really just kind of cycles on itself. And then the things that are uncommon, certainly with mild traumatic brain injuries, would be your psychosis or your aggression. Those are really less common in mild injuries as compared to moderate or severe. Next slide. So as the worse the concussion, the worse the brain injury, the worse the comorbid symptoms. These are a couple of studies looking particularly at the relationship between PTSD, chronic pain, and traumatic brain injury in our veterans. So if you look at the bottom at the pie graph from Dr. Sifu's study of a Iraq and Afghanistan clinic at one of the VA hospitals, you see that the biggest slice of that pie, the purple section, is the patients that have TBI, chronic pain, and PTSD. And so what is the answer then? Unfortunately, for chronic pain, many, many times it's opiates. And opiates then make the patient more disinhibited. They take the frontal lobes offline in many cases. That allows the emergence of the PTSD symptoms. And then, of course, with the opiates, that impairs the cognition worse. So if you're trying to heal from the cognitive impairment of a TBI, so it really kind of, my message is that they continually cycle on themselves. And here's the evidence that it's really a struggle for our veterans in many cases with those polytrauma injuries after the war. Next slide. So let's look then, kind of taking us back a step further. You know, we started with some statistics, then we went a little bit deep into the neuroanatomy, and now we're pulling back a bit to the advice that we give. For those that you're talking to, you know, you're not only doing the work with the clinicians, but you reach a large audience and people who work with clinicians. So you guys in public health really have an advantage to reach lots of people to get these messages out. You know, first thing is to take a thorough history, to ask about, you know, traumatic brain injuries in the past. Patients oftentimes don't connect their current symptoms to a brain injury they've had in the past. And many times if you don't ask, patients don't tell. You want to ask about at the time of the injury, you know, was there unconsciousness? Was there confusion? They may not realize that they had a brain injury. And how long did it take them to feel normal? You know, afterwards, one of the things we really, really look at, the telltale signs, is the time of post-traumatic amnesia, or those days after they've recovered back to full consciousness, how long it took them to feel better again. Ask about the history of substance use, which of course this group are the experts at, not only before and after the injury, but critically at the time of the injury, because that impacted all of those things, as I said, that are done. You know, whether they're in a neuro ICU, whether they have intracranial monitoring, whether they're put in hypothermia, all of those things that impact the recovery, the healing, the recommendations for the treatments. All of those things get impacted by that initial judgment in the ER as to what's going on. And of course, as we learn so often, asking about medications from other healthcare providers. To some extent, I'm a little bit spoiled in the VA system, and that most of our patients use just our system of care. But many times with community care abilities for veterans, there are other programs out there for which veterans are getting care. And the same, of course, for all of you who don't work in a closed HMO type system. You've really got to dig for that, because you will find all kinds of surprises. And of course, checking that state database, because many, many times those meds that we identify in the state database will impact the judgment of choosing those psychiatric meds that you saw talked about in the last lecture's talk, in terms of, you know, the ones the patient should be on or not. And so let's move to our next slide. So mild traumatic brain injury, the clinical practice guidelines. This is something that we are now, I'm one of the authors in this, and we are on our third revision, I think, of this. It was just published. It's available for anyone to use. It's set up to where you don't have to be just looking at veterans by any stretch of the imagination. And the big focus that we use in this for any of our populations is that, you know, the vast majority improve after concussions. It's not the way the media portrayed it during the wars, as we might expect, that most of the time injuries are time limited. Lots and lots of work about education, lots and lots and lots of work to, tell the families, the patients about what's the expected next steps and outcomes. And so this guideline is for anyone, and it's meant to help people in primary care and not in specialty clinics. We're the last stop sort of, we're the specialists, but it's to really help take care of all these patients with traumatic brain injuries at the entry level into medicine. And so next slide. In summary, it's a multifaceted treatment plan. One of the things that we're learning, and as I went through the literature, I saw many, many, many points in the different few papers that are out there about the importance of the whole health concepts, about that really helps the patients that have these combinations of substance abuse and traumatic brain injury, is to make sure that we're really addressing the whole patient. Cognitive rehab programs, the TBI support programs that are out there, the TBI support societies, all of those things are very, very important. Medications, access to the systems, having those case managers, and having the parole officers involved, having the probation officers all involved, really, really makes a difference in kind of treating the whole patient, which of course we all know is what we have to do. But if we can think about these concepts of whole health along with meds and rehab and support systems, it really shows that it makes a difference. And so in the last minute, so I think we're perfect on timing for this. Next slide. What I want to do for you now is to play. Next slide. What I want to do now is we get this loaded up is that's not the button. I think you'll have to click on the link at the bottom that you saw.
Serve their nation.
You got it. Please play this. Thanks.
To get an education or maybe even to see the world.
But for a Catawba County man, the military is in his blood. In fact, he can trace back to the 1600s to find ancestors who fought in all of America's wars.
Then he's the first member of his family since his great-grandfather to get a precious honor, the Purple Heart. Fox 46's Julian Sador introduces us to an Air Force veteran who inherited his call to duty.
At first, I was thinking it was going to be a washout because it was raining. The few times I ever seen it rain in Iraq.
2004, Iraq, the Second Battle of Fallujah. Catawba native Michael Smyer was a Tactical Air Control Party, or TACP, in the Air Force, attached to a unit trying to take back the heavily fortified city. It was on the third day of that battle, November 9th, when the war became real to him.
You could see things, but you can't hear stuff. It's dead silent, and everything's almost like in slow motion. And then it's almost like and then everything's back to reality. So it very spontaneous moment with the sound and everything, but it's almost like everything was in slow motion.
Smyer had been hit by an RPG. The missile ripping through the door of a Humvee he had been driving, hitting him in the leg before taking off the gas pedal, the brake pedal, and then going through the firewall before ricocheting down through the drive shaft and eventually coming to rest in the oil pan.
Then once I came back to knowing, hey, I'm still here, I started doing this number to see if my legs were there and stuff like that. Then I was trying to escape to get out the vehicle because I knew I was hit. I couldn't feel this leg, and I was having burning pains in my lower right leg.
The damage to his foot would end up requiring several surgeries and an implant to help hold it together. Even at 43, Smyer holds on to the boots that he was wearing, the shrapnel still inside, serving as a reminder of a day that he says could have been even worse had it not been for a voice in his ear that he believes came from his cousin who had died the year before.
I could hear a voice say, "Michael, look left," and when I did, I seen the guy come out the door and fire the RPG at me. If I wouldn't have, I actually turned my body like that, or I'd have lost both my legs.
For his injuries, Smyer would get the Purple Heart, something he lightheartedly has given a different name.
I call it the Iraqi Marksmanship Medal, but yes, yeah.
And why does it have that name?
Because I couldn't get out the way.
The Smyer you see now, though, joking, smiling, is a far cry from the young man that returned from Iraq. wounded in more ways than just what meets the eye.
I used to be able to just go into the doctor's office, whether the VA hospital or an outside physician, and all I had to do was give them my background and they would write me just about anything I wanted.
And with every prescription, Smyer would fall deeper and deeper into the grips of addiction.
Because that's what I would hear a doctor say. Oh, it's all right. You've been on this dose for 2 months, 3 months. Now it's time we got to up it a little bit more.
You were just following what they were saying, right?
I was doing exactly what they were saying and didn't know I was actually spiraling downhill during that whole time.
For roughly a decade, he relied on opioids and alcohol to help cope with the mental and physical scars of war.
There's parts of my kids' childhoods that I can't recall because I was basically waking up to take medicine, going to sleep taking medicine, and that was what kept me going, I thought, and it was almost like a blur.
Interestingly enough, though, it was something out of pop culture that woke Smyer up.
It's kind of funny, is after Michael Jackson died and Prince died, I told my wife if I didn't do something, I was going to be just like them.
So he took action, trying things like yoga, acupuncture, meditation, and a doctor at the VA hospital. And now that he's done that, the Michael Smyer you see now is one who can look back and poke fun at things like how awestruck he was meeting President George W. Bush.
Because he said, Michael, how's your foot? And I was like, like, how do you know me? I'm just a peon in this small world, I'm not on that higher level with you.
But also look back fondly on the pride he feels knowing he's been recognized for being an American hero for his actions in Fallujah, November 9th, 2004.
Because, so many of us don't think that our service meant anything, because not everyday people get to see that, and then once you get injured, I hate to put it that way, or wounded, it's almost like then a spotlight's put on you, because they want to hear your voice then, because they know you've been there, done that, and that's one of the most important things.
For Veterans Voices, I'm Julian Sador.
Hey, we can. Okay, if that was the conclusion, the only thing left in my slides that they'll bring back up is the references for those, and I can take questions in the chat, or you guys can find me at the VA. But I think the important thing that I wanted to end the talk on was the inspiration that, as you heard, that opiates can really spiral down, and this is an example of where people were able to move out of it. And so I felt like that was a good place for us to end the talk today, and I'll take any questions in the chat. And again, for those who joined late and didn't hear what I said earlier, I do have the patient's permission to show that. So thank you guys so much for allowing me to be here.
Thank you. And so what we'll do, Robin, is take any questions for you. If you can answer them via text through the Q&A function. If you need any help, just let us know. We can also send that out next week with everything else we'll be sending out. Just want to leave a little space open for Beth on the agenda. And I'll just go ahead and let everyone know our next OPDAAC meeting will be virtual, and we'll be doing it on March 18th in the year of 2022. So look for it for more information from us. It's going to focus on office-based opioid treatment, OBOTs. And again, happy and healthy holiday season to everybody. And I think it would be only right to let Beth close us out. Thank you all so much. And hi,
there
Beth?
we go. I'm unmuted.
Okay, I just wanted to make sure you had it. There you go.
Thank you. So my daughter and I's path, this will be short and sweet, unlike our path with opiates and subsequent brain injury. So by education, 20 years as a real estate broker, full forwarding into working for the Brain Injury Association and sitting on the council working with legislators for change. Thank you for having me. And I'm here mostly just to kind of tell our story. And in hindsight, we're about textbook. Next slide. So this is my daughter, Leslie, and I have 3 daughters. Up in the upper left is Leslie as a child. Her father and I were divorced at 5. There was early childhood adversities, poverty, things as we're looking forward into a population that is affected by self-medicating. This is often the case. She went through 3 years of college and was on track to be a early childhood educator. Next slide. "12 years of battling substance use disorder. As you see, she's was injured many times, and often when we talk about brain injury, we hear about traumatic brain injury, and there's visible evidence of that. One that is under the same umbrella of acquired brain injury, meaning any brain injury that was acquired after birth. Traumatic brain injury we hear about most because there is funding at this time for traumatic brain injury. We also hear about the overlap in corrections with mental illness. And I'd like to point out only 2 years ago in North Carolina legislation was brain injury separated as a separate and standalone definition as the injury that it is, as opposed to being lumped in and defined as with the mental health community. So we are now entering and having seats on the CFAC committees in different commissions and councils. So looking at and listening to everything that has been presented today, because I have traveled that entire path from early childhood development all the way through substance disorder and then into the brain injury arena. There's been a lot of cohesive, and with silver linings, the pandemic, I see all the different areas that are brought together today because we now can meet virtually, and as ironic as it may sound, when this final brain injury happened, I did see it as a silver lining. I believe with her opiate addiction, she would not be with us today had the brain injury not occurred. I would like to bring attention to that brain injury is a silent injury. Prior to this, she was in 6 car accidents, 8 long-term rehabilitation programs. In between, she was consistently in intensive outpatient programs. And so sometimes we say, well, they just need to try, or they just want to, they just need to know and want it, sobriety. Looking back, I understand that there was traumatic brain injury, and many professionals would say that something's missing. We're missing something with her because she tried so hard. And looking to where we are today, I have hope for the screening process, not only for traumatic brain injury, often with those, you can physically see those injuries. The brain injury that affects the population that you serve, the people who substance use, are the non-traumatic brain injuries. So next slide. This is Leslie today. She is 4 years post-brain injury. She spent 2 years in Renew Life Brain Rehabilitation Center, another year in Lutheran Services Group Home, and she is back home with us today. And something that when this first happened, there's a new definition, and it's called opiate amnestic syndrome. Next slide, please. These are particular links. And again, although we know now that Leslie had a traumatic brain injury, invisible, it was a cumulative of concussions, which likely led to her not having success in sobriety recovery. When we were in the hospital, I started really looking into, what was going on with her. And the doctors there, the psychiatrists, the physicians, they continually said that her symptoms was because she was groggy, because she was a drug addict. And I kept pointing towards brain injury. In the slide prior where you see the picture and she has the papers on the wall, she was actually sent to the psychiatric area of the hospital. And we put up those signs because she could not withhold any memory. I was there with her, and I would leave to step out to go to the coffee shop. And when I would come back, she would be in a pure panic where had I been and how did I find her? Although I had been in the hospital with her for over a month. We have moved forward. I would now consider her a survivor and a thriver. Looking at the programs that are being pulled together, including the medication assisted. I know that, we are saving lives immediately. And I know that we'll continue to look at, what are the next steps so far as exit plans. And there's some things that we can see and some that we cannot see. This last link down at the bottom was actually published this month. I encourage you to look at this aspect of brain injury. One that when we talk about mental illness, the overlap of the symptoms of brain injury, and we look at a person and they look whole, they look besides their behaviors, that they are not, that these brain injuries are not missed. It's 87% of those incarcerated in jail and prison studies have noted that they have either had a period of unconsciousness, whether it be overdose or this type of injury. The opioid-related amnesia is due to the fast metabolism of the fentanyl, where it goes in. It does not damage all of the brain, simply the hippocampus. Massachusetts is the only state that is focusing on this at this time. So if Massachusetts can do it, I'd love to see this expand along with traumatic brain injury. And our last slide. These are some additional links to the overlap of traumatic brain injury. And a lot of these, because we are kind of coined to always say traumatic brain injury, Acquired brain injury includes, again, the traumatic brain injuries and the non-traumatic brain injuries. The violence on the street, the vehicle accidents, certainly are high prevalence in the substance use disorder population. Likewise are the overdoses. If I brought something forward, it would be to consider also advocating for funding for non-traumatic brain injuries, as they currently are not in the state of North Carolina. The Brain Injury Association, the last two links, they have a learning center for the overlap of substance use and brain injury. And also, as a community and as the council, our public policy committee has now started a subcommittee, and that is for the justice and the correction involved population. So I'll just kind of leave you with, my experience did not start in the healthcare, other than being a holistic bodywork therapist. And when I look at the community that comes together for people with disabilities, just as when working with someone in holistic bodywork, we cannot address only the shoulders or only the lower back. We are all very connected. And I can see coming, in an ideal world, and I see just in this presentation, the different sectors that are coming together. But looking at it as a whole and reflecting on my path with Leslie and my family, all the way back to collaborating with the early childhood development, where alexithymia, we find that would be non-traumatic, where yelling and screaming at a child actually changes their brain and their inability as an adult to connect to other people in a healthy way. Mental health, domestic and street violence, substance use disorder, brain injury, acquired, traumatic and non-traumatic, the correction system, and last, housing authority, that we really think outside of the box. And their stories of where they're taking the empty malls and bringing in programs for the homeless and the post-incarcerated. So thank you for taking the time and allowing me to give you a short synopsis of a long story. And, I'll leave you with this. We all tend to focus on what's in our face. And I am an example of that. But the path I've covered has brought me through being an early childhood provider when my children were young, very hyper-focused on substance use when my daughter was going through that. And now I'm very heavily as well into the Brain Injury Association. And, Mother Teresa once said, and I think this is true for all of us, I alone cannot change the world, but I can cast a stone across the waters to create many ripples. Thank you.
Thank you, Beth. And thank you all so much.